Hi, everyone. Thank you for joining us tonight. If you haven't seen the email, we are recruiting for next year's leadership. So fill out the application if you're going to be entering fellowship next year. It is my pleasure to introduce Dr. Papu. Dr. Papu is a native of Greece. He graduated medical school from the Medical School of the Technical University of Munich with honors in 2006 and completed a PhD on human stem cells at the research laboratory of the Ludwig Maximilian University of Munich, Germany. Dr. Papu subsequently completed his general surgery residency training at the Johns Hopkins Hospital in 2014 with a research fellowship in surgical oncology at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. He has completed the ACGME accredited clinical fellowship in colon and rectal surgery at New York Presbyterian / Weill Cornell and the Memorial Sloan Kettering Cancer Center in 2015. Dr. Papu is currently an assistant professor within the Division of Colorectal Surgery at Memorial Sloan Kettering Cancer Center and assistant professor of surgery at Weill Cornell Medical College. And he will be speaking to us about current trials in colorectal surgery. Dr. Papu, I'll let you take it away.
All right, thank you very much for the kind introduction, Joyce. Good evening, everyone. I would like to give you a brief overview of the journey that we have taken in colorectal surgery, uh, taking care of colorectal cancer patients over the past century plus. So the topic of tonight's session is studies and trials in colorectal cancer, past, present, and future. I have no financial disclosures. Like any talk on colorectal cancer, I think we have to start with Dr. Ernest Miles. He was a brilliant surgeon in the UK, and he started by looking at his outcomes from the most common procedure that used to be done for rectal cancer back in that day, and it was a perineal resection. It was essentially a transanal excision. That was the treatment of choice for rectal cancer. And he noted that doing pathologic specimen analysis and post-mortem analysis of patients who died, he saw that virtually everyone had a local recurrence. The vast majority of patients that he had taken care of, 95%, and one of the patients ultimately died as a result of the recurrence. And he popularized the idea that cancer spread in a spherical way, in a downward, lateral, and upward fashion. And that's what led him to propose the abdominoperineal resection as the more oncological, optimal surgery for rectal cancer. He published his landmark paper in 1908 at the Lancet Journal. And he looked at his outcomes of 400 APRs, and he states in the paper that the number of recurrences was exceedingly small, which I find actually very astonishing, that even the fact that the recurrence rate dropped from 95% to 28% was a remarkable feat over the course of 20 to 30 years. Mortality still remained high with APR 7.5%. And he published his follow-up in 1931 with the outcomes of his patients. So this was a landmark move in taking care of rectal cancer patients who moved from a transanal resection to an abdominoperineal resection by studying the pathology of the specimens and understanding a little better the mode of spread of cancer. The next landmark trial in rectal cancer was the Swedish rectal cancer trial. This was published in the New England Journal of Medicine, 1997. And this is the title of the trial. It was called Improved Survival with Preoperative Radiation Therapy in Resectable Rectal Cancer. It was a large trial that included 1,168 patients with resectable rectal cancer. These patients in Sweden underwent preoperative radiation therapy. The standard radiation therapy for Sweden was short course radiation therapy, which was born out of convenience. People would come from more remote areas of Sweden to the big centers. They would get radiation therapy over the course of a week, and then they would undergo surgery the following week. And they randomized the patients to undergo radiation therapy or surgery first. And this is one of the few trials in rectal cancer which actually showed reduction of death by preoperative radiation therapy. So they saw actually that the 5-year local recurrence rate dropped to 11% with preoperative radiation therapy. What was remarkable in this trial was, as you can see, that the local recurrence rate for patients who underwent surgery first was 27%. So over the course of a century, since the original description by Dr. Miles, the local recurrence up to 30 years ago was still very significant, up to 30%. And what was remarkable in this trial was that there was a difference in a significant difference in 5-year survival. So again, this is one of the very few trials that actually showed a difference in survival in rectal cancer with the adoption of a neoadjuvant mode of therapy. This is the probability of local recurrence, and you can see people who had surgery alone had a far higher risk of having a local recurrence. And this is the survival curve. As you can see again, people who had surgery first had a far lower 5-year survival compared to those that had preoperative short course radiation therapy. And this was a key trial in rectal cancer, and out of this one was born the idea of neoadjuvant treatment. Next big step in surgery was the era of total mesorectal excision surgery, which was popularized by Dr. Bill Hield. Many of you may have already read the original paper, which was which was published in 1982, the mesorectomy in rectal cancer surgery, the clue to pelvic recurrence. Again, Dr. Bill Hield meticulously looked in a pathological laboratory, 6 cases of local recurrence, and what he saw was that most of the recurrences were taking place in the mesorectal fat that was posterior to the rectum. And he popularized the idea of sharp mesorectal excision along the embryological plane and complete removal of the mesorectum. And based on that, he published his experience with 113 low anterior resections and the 2-year follow-up where he had no recurrences. And as he notes in that paper, these promising early figures suggest at the very least that local recurrence is directly related to the technique of pelvic dissection. And we suggest that complete removal of the mesorectum encompasses the most dangerous and prevalent field of spread. Again, landmark study, and it shows you how meticulous analysis and going back to the basics, studying from your failures can lead to innovation and can lead to improvement. These results at the beginning were hardly believable. This is going from a known local recurrence rate of 30% to 0. And as you can understand, people had a hard time accepting these results. But what Dr. Hield did actually was he went to Nordic countries and he popularized the type of surgery. He taught other surgeons how to do the surgery in the same way. And other countries in Norway, Sweden, Denmark adopted his technique, and they saw improvement in their outcomes. So this is what we call the Hield wave that took place. And this is another follow-up study from his results with 405 TMEs, a 5-year local recurrence rate of 3%, 10-year local recurrence of 4%, and 5-year disease-free survival of 80%, and a 10-year disease-free survival 78%. Dr. Hield published his follow-up data in the Lancet and Archives of Surgery, and he actually invited a Canadian surgeon to look into his results so that they would become more believable. But more importantly, he traveled to the Netherlands, Denmark, Sweden, Norway, and he developed these workshops, taught other surgeons how to follow the proper surgical principles that we all follow these days. And this led to low recurrence rates and improved survival in all other countries with the workshops. And he brought along with him pathologists, and what they were able to do were, by looking at the specimens, they were able to understand better that quality of the specimen correlated with survival. So Dr. Phil Quirk, the pathologist at Basingstoke who was working with him, would come along to these workshops, and they were able to see that the quality of TME dissection correlated with less recurrence and improved survival. And these results have been published where, complete mesorectomy, as you can see here, had actually significantly lower overall recurrence rate compared to incomplete mesorectum. And this is the survival curves. As you can see, complete TME having a complete mesorectum was correlated with improved survival compared to incomplete mesorectal excision. This led to the so-called Dutch TME trial. People started wondering if now with the adoption of excellent surgical technique, maybe we don't need to use preoperative radiation therapy. And this was the question that the Dutch TME trial tried to answer. They enrolled 1,861 patients with resectable rectal cancer, and the patients were randomized to either undergo preoperative radiation therapy followed by TME, which, as we had known from the Swedish trial, had led to improved survival and local recurrence versus TME alone. As you can see, a sizable number of patients in each arm. What they did see was, even in the modern era of TME technique, the 2-year local recurrence was significantly better with preoperative radiation therapy, 2.4% versus 8% with surgery alone. And the 10-year local recurrence rate was lower in the preoperative radiation therapy arm, 5% versus 11% in the surgery alone arm. Here you can see the curves, risk of local recurrence far higher with TME, double, actually, so 3 times higher compared to preoperative radiation therapy and TME. What we did see was they were not able to replicate the finding from the Swedish trial. So the local recurrence rate was higher in the surgery alone group, but the overall survival was the same between the two groups, as you can see in the survival curves. And that led to the next large trial, the German TME trial. As we said, so far, people had been using short course radiation therapy, which was born out of convenience. The idea of long course radiation therapy was that you can give smaller doses over a longer period of time, and they also use 5-FU. So they thought that by doing long course chemoradiation, by adding a chemotherapy agent, capecitabine, maybe we will see improvement in survival. So the German TME trial, the title was Preoperative versus Postoperative Chemoradiation Therapy for Rectal Cancer, enrolled 421 locally advanced rectal cancers that underwent long course radiation therapy followed by TME versus 402 patients who underwent TME followed by adjuvant chemoradiation. Unfortunately, they did not see a difference in survival, which was the primary outcome of the study. So it was a negative study in that respect. But what it really consolidated was that by doing chemoradiation therapy prior to surgery, you had a lower chance of local recurrence. So they showed that the local recurrence was half if you started preoperative long course radiation therapy. So it emphasized, just like the Swedish and the Dutch TME trial, that if you want to employ chemoradiation or any neoadjuvant therapy, it's better to do that prior to surgery. You can see here, this is the cumulative incidence of distant disease. There was no difference. And as you can see here, the cumulative incidence of local recurrence was twice lower in those that underwent long course radiation therapy prior to surgery. This study had been published in New England Journal of Medicine in 2004, and I believe it really consolidated the role of long course radiation therapy, of chemoradiation therapy, as standard of care in a neoadjuvant fashion for rectal cancer. What was also very interesting in this trial was that if you look at the number of patients who underwent sphincter saving surgery, it was increased by the use of long course radiation therapy. So those that underwent preoperative radiation therapy, 40% of them were able to undergo low anterior resection versus APR. Those that had chemoradiation therapy afterwards, only 19% of them were able to have sphincter saving surgery. So it established something that we knew, that long course radiation therapy can make the tumor smaller, and it can let it regress, make sure that it goes away from the sphincter complex so that you can do sphincter saving surgery. And after that, the Swedes did another study, the so-called Stockholm III study. It's a little bit of a complex study because they use different radiation therapy regimens in respect to fractionation time and time to surgery. It's a multi-center randomized non-blinded phase 3 non-inferiority trial. And they had, again, they used a short course radiation therapy, and in one arm they used short course radiation therapy followed by immediate surgery next week, which is what they had been doing all this time, versus delayed surgery, meaning they would do short course radiation therapy, but they would delay surgery for at least 4 to 8 weeks from the end of short course radiation therapy. and they had a long course radiation therapy. Again, it was only radiation therapy with delay for surgery. And what they really saw was that the local recurrence was the same in all arms. As you can see here, in all 3 arms that underwent preoperative radiation therapy, there was no difference in local recurrence, but the postoperative complications were significantly reduced with delay to surgery. So if you combined the short course and the long course radiation therapy with delay for surgery, those had a much lower chance for complications related to surgery. As you can see here, any surgical complication was much lower the risk if you underwent short course radiation therapy or long course with delay to surgery. So this trial established the fact that it's better to wait after the end of radiation therapy and prior to surgical intervention for at least 4 to 8 weeks. During that time, another landmark trial took place, the trial by Dr. Angelita Habergama. This was one of the key trials that established the role or the potential of long course radiation therapy in being able to actually cure people completely and being able to avoid surgery. So this was a landmark study that was published in Annals of Surgery in 2004. This is the title, Operative versus Non-Operative Treatment for Stage 0 Distal Rectal Cancer Following Chemoradiation Therapy. In this trial, Dr. Habergama included 265 patients with distal rectal cancer treated with long-course radiation therapy. Patients with incomplete clinical response were treated by surgery and resulting in a pathologic response, essentially, and they were compared to patients with a clinical complete response treated by non-operative management. There were 71 patients with a clinical complete response who avoided surgery versus 22 patients who underwent APR but had no cancer on final pathology. What she saw was that the 5-year overall and disease-free survival were excellent in both groups, including this, surgery versus non-operative management group. You can see here the survival curves for both groups, observation and resection. They were equivalent, both disease-free survival in A and overall survival. This really established the notion that not everyone needs surgery. When Dr. Angelita Habergama first published these results and she was presenting them to conferences in the world, she was met with a lot of criticism. People had a hard time accepting non-operative management for rectal cancer. But overall, over the past 20 years, many centers have accepted and have adopted non-operative management as a viable alternative treatment. Along those lines, as we saw over the past 20 years, people were increasingly using neoadjuvant treatments or treatment prior to surgery. And during that time, the idea for total neoadjuvant therapy was born. Total neoadjuvant therapy means that you also employ chemotherapy and chemoradiation therapy prior to surgery. Again, this is the standard way that we were treating patients, chemoradiation surgery followed by adjuvant chemotherapy. This was the standard for a long time. The first iteration of total neoadjuvant therapy was chemotherapy, chemoradiation, followed by surgery. So that was the innovation. We thought we have started doing long course radiation therapy or neoadjuvant radiation therapy prior to surgery. We haven't noticed an increase in survival. What if we also employ chemotherapy in a neoadjuvant fashion? Maybe this will lead to an increase in survival. The first 2 studies were the landmark studies published by Dr. Andrea Sersek and Dr. Lensals in 2015 and 2018. And what we found out was that TNT correlated with higher complete response. So looking at 811 patients who were treated at MSK with locally advanced rectal cancer, looking at patients that had chemoradiation therapy alone with planned adjuvant chemotherapy versus patients who received TNT, and the complete response, so the composite of pathologic complete response and clinical complete response was 36% in the TNT cohort compared to 21% in the chemo-RT arm. So we saw that actually it's effective, and the idea was that maybe by employing total neoadjuvant therapy, you can increase the survival. As you can see here, having a pathologic complete response, which is the blue one, correlated with improved survival. So this made a reasonable argument in favor of doing total neoadjuvant therapy in an effort to improve survival. And after that, many trials were performed to test the idea of total neoadjuvant therapy. These are the most commonly referenced total neoadjuvant therapy trials, the most famous ones, the German rectal cancer trial, the Rapido trial, which used short-course radiation therapy, the OPRA trial, and the Prodige 23 trial. So the German trial was a total neoadjuvant therapy trial. It had two arms. In Group A, patients underwent, in both arms, they underwent total neoadjuvant therapy. The only difference between the two arms was the timing and the sequence, really, of the total neoadjuvant therapy. In Group A, patients underwent induction chemotherapy, followed by consolidation chemoradiation therapy. And in Group B, they started with chemoradiation, and they followed by consolidation chemotherapy. So this trial was published in JCO in 2019. It was led by Dr. Focas. And what we saw was that by starting with chemotherapy, with chemoradiation, and following that with consolidation chemotherapy, we had an improved pathologic complete response, 25% versus 17%, but worse compliance to chemotherapy. And what we also saw was that the longer interval from chemoradiation to surgery did not increase surgical morbidity. And there were no difference in oncologic endpoints. These are the graphs, the disease-free survival and the risk of local recurrence between the two groups. What was important, what we found out from this trial was that A, it was safe to do total neoadjuvant therapy in a randomized trial. B, that most likely chemoradiation first, followed by consolidation chemotherapy, is probably the best way to do total neoadjuvant therapy. And C, very important for surgeons, that the delay from chemoradiation therapy to surgery did not add more morbidity. Another famous total neoadjuvant therapy trial is the Rapido trial, which was performed in the Netherlands. This is the title of the trial: short course radiation therapy followed by chemotherapy before total mesorectal excision in locally advanced rectal cancer. And this trial was a neoadjuvant therapy trial in the standard arm, which is shown in the upper portion. Patients would undergo short course radiation therapy, and after a delay of 8 weeks, they underwent surgery, and afterwards they underwent adjuvant chemotherapy. And in the experimental arm, which is in the lower portion of the figure, patients would undergo short course radiation therapy, followed by consolidation chemotherapy, followed by surgery. So the only difference or main difference really in this trial from the other total neoadjuvant therapy trials was that they used short course radiation therapy. And as many of you know, they used a composite outcome as a primary outcome, and they saw that actually patients who underwent short course radiation therapy, followed by chemotherapy, followed by surgery, they had actually worse outcomes and higher rate of metastases, despite having a higher rate of pathologic complete response. As you can see, those that had short course radiation therapy had in the right part of the screen, 28% of pathologic complete response versus 14%. So the data were counterintuitive. People could not understand how come that actually you have a pathologic complete response in a higher number of patients, but the composite outcome was actually worse in those that had total neoadjuvant therapy. And that was actually explained in a follow-up paper of the Rapido trial, where they published the 5-year results, where they saw there was a higher local recurrence. So it seems that all these results were related to surgical technique. In the experimental group, in those that had total neoadjuvant therapy with short course radiation therapy, local recurrence was more common, and they had more commonly a breached mesorectum, extremely high, so 21% versus 4%. And although the Rapido trial demonstrated favorable outcomes concerning systemic control with the TNT approach, the long-term results indicate risk of compromising local control with short course radiation therapy. And it's remarkable, actually. So the overall survival was similar between the two groups, but those that had short course radiation therapy followed by chemotherapy had worse outcomes in terms of local recurrence. And as you can see here, there was a higher rate of local recurrences in the experimental arm, in those that had short course radiation therapy followed by chemotherapy. So what we really learned from the Rapido trial was that doing short course radiation therapy and waiting so long afterwards actually led to a lot of pelvic fibrosis and made surgery more difficult for those surgeons and led naturally to worse oncologic outcomes. It's a very interesting trial. So, the main, I would say, teaching point from that trial is that most likely the best mode of neoadjuvant therapy would be, in terms of radiation therapy, would be long course radiation therapy versus a short course. It seems that long course led to less fibrosis and made surgery feasible even after the use of total neoadjuvant therapy. And during that time, the idea of non-operative management was consolidated in the United States, and Dr. Garcia Aguilar at Memorial Sloan Kettering led the first randomized trial to test total neoadjuvant therapy with the option of watch and wait. Now, this was the OPRA trial. It was a randomized trial. It had two arms where the sequence was tested. In one arm, patients would undergo induction chemotherapy, followed by chemoradiation. In arm two, they would undergo chemoradiation, followed by consolidation chemotherapy. And based on response, patients who had incomplete response, they would undergo surgery. Those that had a complete response, they would undergo watch and wait. It was a multi-center phase 2 trial. Target accrual was 202 patients. As you can see here, again, the schema, these were locally advanced rectal cancer patients, less than 7 centimeters from the anal verge. You can see the two arms of the treatment: chemotherapy first, followed by chemoradiation, versus chemoradiation first, followed by consolidation chemotherapy. And then patients were reassessed, and based on their response, they would undergo either watch and wait or surgery. And the remarkable thing in this trial was that we saw no difference in disease-free survival compared to historical controls, but we saw higher rates of organ preservation with chemoradiation therapy followed by consolidation chemotherapy. So this trial reiterated that this right sequence for total neoadjuvant therapy is chemoradiation therapy first, followed by consolidation chemotherapy, as we had seen in the German trial. What was really important is that what we call now TME-free survival, which was the new metric that was born out of the trial, so the ability to avoid surgery, was much, much higher at 3 years. If you started with chemoradiation therapy first, it was almost 60%. And if you had chemotherapy followed by chemoradiation, it was 40%. We still, and again, no difference in 3-year disease-free survival or distant metastasis-free survival. We don't know, we cannot explain this phenomenon. It's very interesting, it's very intriguing. Many people think that the sequence of chemoradiation therapy first, followed by chemotherapy, gives you more time, gives radiation therapy more time to work and for the tumor to respond. Other people think that chemoradiation therapy first maybe works better because your immune system is in a better shape. And other people think that the chemoradiation can damage the cells so that the consolidation chemotherapy can be more effective, can be delivered inside the cells after they have been damaged by chemoradiation. Either way, we saw, this trial paved the way in terms of total neoadjuvant therapy as A, being accepted, that it can be done in a randomized trial, and B, that the right sequence is probably chemoradiation therapy followed by consolidation chemotherapy. Here you can see that the two groups had very similar outcomes. As you can see, there is still some patients who underwent surgery, and a significant number had a pathologic complete response. So there is still room for improvement for us surgeons. Some people could have been spared surgery possibly. So that's something that, there is room for improvement even among expert surgeons to find out who that 10% of patients are who maybe don't necessarily need surgery. The unanswered questions from the original paper were, do patients who develop regrowth and require salvage TME do worse than those that had upfront TME? Meaning, if we offer patients the chance to watch and wait, but then they have a regrowth, do they have similar outcomes compared to those that had immediate surgery? We wanted to compare the 5-year disease-free survival between those that had TME at that point and TME after tumor regrowth. And we looked at the 5-year organ preservation rate between the two groups, and we looked at the timing of regrowth. And this was published in a subsequent paper in 2024 in JCO with a median follow-up of 5.1 years. At the time that we saw patients in clinic after the end of total neoadjuvant therapy, a high number, 74%, were offered watch and wait. So TNT was effective in achieving a clinical complete response in 74% of patients. And as you can see, 36% of patients developed a regrowth, 44% in the chemotherapy followed by chemoradiation therapy arm, and 29% in chemoradiation therapy followed by consolidation chemotherapy arm. And 94% of regrowths occurred within 2 years, and 99% occurred within 3 years after restaging. What we learned from this trial was that it consolidated that the 5-year outcomes were similar between the two groups, as you can see in the disease-free survival of the two arms. The organ preservation rate was higher in those that had consolidation chemotherapy, so those that had chemoradiation therapy first, followed by chemotherapy. And as you can see in the lower graph, those that had TME at the time of restaging versus those that underwent surgery when they had regrowth, there was absolutely no difference in survival. So the watch and wait approach was safe. We were not compromising the survival of patients who underwent watch and wait. Another landmark trial in total neoadjuvant therapy was the Prodige trial, which was performed in France. This was a total neoadjuvant therapy trial with FOLFIRINOX versus preoperative chemoradiation in patients with locally advanced rectal cancer. It's the Unicancer GI trial. These patients were locally advanced rectal cancer patients. In the standard of care arm, they would undergo long course radiation therapy followed by surgery, followed by adjuvant FOLFOX, which had been the standard for a long time. And in the TNT arm, they would undergo induction FOLFIRINOX for 6 cycles, approximately 3 months, followed by chemoradiation, followed by TME, followed by adjuvant chemotherapy. So the induction chemotherapy was FOLFIRINOX, and the adjuvant chemotherapy was FOLFOX. So the only difference between the two arms was that in the experimental arm, there were 6 cycles, so almost 3 months of FOLFIRINOX. And this trial, the primary endpoint was disease-free survival, and they had a few secondary endpoints, including toxicity, pathologic complete response, metastasis-free survival, quality of life, and overall survival. This was a remarkable trial because, as I will show you right now, the characteristics were similar between the two groups in terms of demographics and clinical characteristics of the tumor. This was remarkable because the 7-year disease-free survival was higher in patients who underwent total neoadjuvant therapy with FOLFIRINOX first. And this is reminiscent of the Swedish trial when we started the talk, where they had actually shown improvement in survival. So this was the first time since 1997 where we have a trial that shows improvement in disease-free survival. It is intriguing. Again, the 7-year metastasis-free survival was higher in those that had neoadjuvant FOLFIRINOX, and the overall survival was higher in those that underwent FOLFIRINOX. Now, as you can see in this curve, the drop in survival happens in the first year. And again, the result is very intriguing. I don't think anyone has an explanation. We have to see if these results will be replicated in the future. One possible explanation for these results could possibly be that it is really related to the effect of the chemotherapy. Another one is that something happened in the chemoradiation followed by surgery arm that led to that significant drop in the first year. Maybe there were more surgical events in that first year, surgical deaths, or something that led to this difference in the survival. This is something that remains to be confirmed in subsequent studies. The conclusions of these 7-year outcomes of the Prodige trial were that induction chemotherapy with FOLFIRINOX before chemoradiation therapy improves overall survival. The disease-free survival and metastasis-free survival benefits are durable. The safety profile was unchanged. There was no increase in local recurrences. There was similar or improved quality of life with neoadjuvant therapy. And TNT with FOLFIRINOX should be considered as one of the best options of care in patients with locally advanced rectal cancer. And this strategy is now investigated in rectal cancer for tailored management according to response to induction FOLFIRINOX. So, the Prodige trial had shown improvement with increasing use of total neoadjuvant therapy. But at the same time, there were concerns about the side effects of chemoradiation. So out of that concern, the idea of de-escalation was born. We had found out that you can, out of the three components of neoadjuvant treatment, including chemoradiation, chemotherapy, and surgery, you can definitely take one out of them out, surgery, for example, in the OPRA trial. So the idea was, can you take another component out of the preoperative treatment, for example, the chemoradiation, which had been the standard of care since the time of the Swedish and the Dutch TME trials. So the PROSPECT trial was a trial in locally advanced rectal cancer. And the hypothesis was that many rectal cancer patients can receive curative intent treatment without pelvic chemoradiation. This trial is particularly relevant these days, where we treat young onset rectal cancer patients. As you know, chemoradiation can affect sterility, fertility, it can affect sexual function. So the idea was that maybe some patients don't necessarily need preoperative radiation therapy. This was a randomized trial that was performed in many centers, including the United States, Canada, and Switzerland. Patients were locally advanced rectal cancer patients, and they were randomized 1-to-1 to undergo either preoperative chemoradiation followed by surgery versus systemic chemotherapy with possible use of chemoradiation if there was poor response to chemotherapy. This is the trial schema. As you can see in the standard arm, patients underwent neoadjuvant chemoradiation, followed by surgery, followed by adjuvant chemotherapy. And in the experimental arm, patients underwent 6 cycles of FOLFOX that were restaged. If there was at least 20% response of the tumor to FOLFOX, they underwent surgery. If there was less than 20% response, patients underwent chemoradiation first, and then they underwent surgery. That treatment response was based mostly on both MRI and endoscopic response that the treating surgeon would perform. Inclusion criteria were locally advanced rectal cancer patients, patients who were candidates for sphincter saving surgery, and exclusion criteria were very low rectal cancer patients that would require an APR, T4 tumors, and high number of lymph nodes, more than 4 pelvic lymph nodes with at least 1 centimeter in length and short axis. The primary endpoint was disease-free survival, and several secondary endpoints were measured, including local recurrence, overall survival, R0 resection, complete pathologic response, toxicity, and quality of life. This trial was a non-inferiority trial, and as you can see, the patient characteristics were similar between the two groups. And as you may already know, the trial showed that FOLFOX followed by selective use of chemoradiation was non-inferior compared to the standard chemoradiation followed by surgery. This is the hazards ratio. You can see the non-inferiority criterion was met for this trial. And the local recurrence free survival was excellent. As you can see in both arms, the local recurrence rate was less than 3%. The local recurrence-free survival was 98.2% in the systemic chemotherapy, and in the chemoradiation therapy arm was 98%. So excellent local recurrence-free survival. The overall survival between the two arms was very similar, 89% and 90%. And as you can see here, chemotherapy was effective. 22% of patients had a pathologic complete response after FOLFOX. And the rate was similar in those that underwent chemoradiation followed by surgery, 24%. Very low rate of positive margins and very high rates of R0 resection in both arms. And as you can see here, both arms, patients in both arms successfully received adjuvant chemotherapy. And very importantly, a very small number of patients, 9% of those that underwent systemic chemotherapy. So in the experimental arm, only 9% of those required neoadjuvant chemoradiation because they didn't have either they didn't have response to the chemotherapy or they could not tolerate FOLFOX. So what we learned from this trial, and the toxicity, as you can see here, was acceptable, as expected, more diarrhea in the radiation therapy group and more neuropathy in the FOLFOX group. But really what we learned from this trial was that in selected patients for maybe low-risk cancers where the mesorectal fascia is not threatened, you can employ neoadjuvant systemic chemotherapy and avoid chemoradiation, especially if fertility and sexual function are big concerns, as they are in our young onset rectal cancer patients. During the same time, we realized that many patients actually may have mismatch repair deficiency. And during that time, we started using immunotherapy for rectal cancer. And we have conducted a prospective phase 2 study where we used single agent dostarlimab, a PD-1 monoclonal antibody, for patients who had mismatch repair deficient rectal cancers. It was administered every 3 weeks for 6 months. They were locally advanced stage 2 and stage 3 rectal cancer patients. The vast majority of patients were either Lynch syndrome or they had a POL-E mutation where they had a high rate of mutations. And as you probably already know, a total of 12 patients had a completed treatment with dostarlimab, and they underwent at least 6 months of follow-up at that point, and all 12 patients had no evidence of tumor on endoscopic examination or MRI, so they did not require chemoradiation or surgery. And the adverse effects reported by the patients were minimal. So the teaching point from that trial was that it is imperative to check mismatch repair status for all rectal cancer patients, and if they have mismatch repair deficiency, probably the best neoadjuvant treatment would be immunotherapy. There are several TNT trials that are in progress, and they may change the neoadjuvant treatment paradigm in the future. I'm mentioning some of them. The German trial, which is a phase 3 randomized controlled trial, where they're studying whether short course radiation therapy will have similar rates of 3-year organ preservation. So they are randomized patients to undergo either short course radiation therapy, which was used in the Rapido trial, versus the long course radiation therapy followed by consolidation FOLFOX, which was used in the previous German trial and the OPRA trial. And we have also the CHOW trial, which is the trial conducted in Brazil. It's a phase 3 randomized controlled trial of patients with locally advanced low to mid rectal cancer patients, and they're undergoing long course radiation therapy followed by consolidation FOLFOX or chemoradiation therapy followed by capecitabine. The idea is that if you avoid oxaliplatin, you may avoid a lot of toxicity, neuropathy that comes with FOLFOX. And again, the primary outcome is clinical complete response. And there is the Ensemble trial, a trial in Japan, which is a phase 3 randomized controlled trial of locally advanced rectal cancer patients. And they're being randomized to either short course followed by consolidation chemotherapy versus short course followed by consolidation chemotherapy with Capox series. So almost the winner from the Prodige trial. And again, the primary outcome is 3-year disease-free survival and organ preservation survival. And last but not least, the trial that is being conducted in the United States, led by Dr. Josh Smith here at Memorial Sloan Kettering, which is called the Janus trial. And these are patients with locally advanced rectal cancer, and they're being randomized to either undergo long course radiation therapy followed by FOLFOX. So this is the winner arm from the OPRA trial, versus long course radiation therapy followed by FOLFIRINOX, which, as we had seen from the Prodige trial, had improved survival. And the primary outcome is clinical complete response rate, and in the phase 3 arm, 3-year disease-free survival. Now, as we discussed before, the trial of Dr. Serseks led to the notion that neoadjuvant immunotherapy can be done in mismatch repair deficient patients. That trial had been published several years ago, and a follow-up update was just published this past week in New England Journal of Medicine. But the idea was born that maybe you can use immunotherapy, immune checkpoint inhibition in patients with mismatch repair proficient rectal cancer. And here I'm summarizing some of the trials that have been done so far. The PRECOM trial, the NECTAR trial, and the AVE rectal trial. These are all recent trials with locally advanced rectal cancer. These are single-arm trials, and they have used different treatment interventions that have included short course radiation therapy, for example, in the PRECOM trial, followed by consolidation chemotherapy with CAPOX, followed by immunotherapy with envafolimab. And the primary endpoint was pathologic complete response. They had an excellent pathologic complete response of 62%. In the nectal trial, which was a single-arm trial, they had long course radiation therapy, followed by capecitabine, followed by tislelizumab. Again, primary endpoint was pathologic complete response rate. It was a little lower, 40%. And in the rectal trial, which was a single-arm trial, where they had used short course radiation therapy, followed by chemotherapy, followed by immunotherapy with avelumab. Again, looking at the pathologic complete response, also modest 37.5% rate. There are trials right now that are underway, which are randomized trials. And these are some trials here that are representative, including the Union, the Torch, and the Energy GI 002 trial. They have shown that use of immunotherapy in some of these cases has had success. As you can see, for example, in the Union trial, where they used short course radiation therapy followed by CAPOX, followed by camrelizumab, there was a pathologic complete response rate of 39%. And in the standard arm, where they had short course radiation therapy followed by CAPOX, that pathologic complete response was only 15%. So 39.8 versus 15.3, there was a significant difference in the two arms. Other studies have not shown that big difference. So this is something that remains to be seen in the Energy GI 002. Those that underwent FOLFOX long course radiation therapy versus those that had FOLFOX long course radiation therapy plus pembrolizumab. As you can see here, the pathologic complete response was similar, and the clinical complete response was very similar. So it remains to be seen what is the right combination of neoadjuvant treatment. As you can see, people have started using immunotherapy prior to surgery for mismatch repair proficient tumors, but we're still not sure what the right sequence is. Should we start with immunotherapy first and then do radiation therapy or chemotherapy? Or should we do radiation therapy first, followed by immunotherapy? This is still unresolved, and it is a matter of ongoing trials. These are more trials that are ongoing with use of immunotherapy and total neoadjuvant therapy, including the Stellar 3, PRECOM, R, Unicorn, Torch 2, and TNT-I trials. All of these are randomized trials that include immunotherapy in one of their arms, and the results will be something to look out for in the future. And last but not least, in terms of advances in surgical technique, there has been a long debate in terms of the TME and the type of surgery. For a long time, we have been doing total mesorectal excision in open fashion. We went from open to laparoscopy. And over the past years, we have been going from laparoscopy to robotics. As you can see here, many trials have been done in rectal cancer, establishing that laparoscopy is safe. The classic trial, COLOR 2 trial, the Korean trial, a la carte, and the Z6051 trials were all trials where patients were randomized to undergo open versus laparoscopic surgery. As you already know, in the COLOR trial, the overall survival was the same, and the ECOSOG trial also the same. There was some concern initially with the ECOSOG trial by Dr. Fleshman and the Z6051 that maybe when they were looking at the short-term composite outcome of mesorectal excision, the quality of the mesorectum, that maybe laparoscopy did not have such a good mesorectum, but as you can see, the long-term results of the studies did not confirm that finding. Overall, laparoscopy was safe. The problem with laparoscopy in the real world is that it's technically challenging. The instrumentation is still cumbersome. It's long, rigid, it's not articulated. You have two-dimensional visualization. You require the skillful assistance. And ergonomics can be challenging, specifically in obese patients. And especially if you work in men with a narrow space, it can be very, very difficult. So overall, there was a very low adoption of laparoscopic TME. Even in specialized centers, maybe 30% of TME was performed laparoscopically in the United States. And during that time, the robotic technology advanced. The benefits of the robot is that we have a three-dimensional view of the field, motion scaling, we have articulating instruments, enhanced precision. The robot suppresses hand tremor. You have more surgeon control of the camera, improved ergonomics. And the previous trials had seen that with laparoscopic versus robotic TME, the conversion rate seemed to favor robotics. So the idea of the ROLARR trial was born, and patients were randomized to undergo either laparoscopic versus robotic surgery. The trial included 40 surgeons in 10 countries, and the surgeons who recruited patients had significant experience, at least 91.5 million number of laparoscopic operations versus 50 robotic operations. The trial was a negative trial essentially because the primary endpoint was conversion to open. And as you can see here, the conversion rates were very high still with robotic surgery, 8.1%. So the trial did not show a difference between laparoscopic TME versus robotic TME. But on an a priori defined subgroup analysis, those that underwent robotic TME had favorable outcomes, specifically for men. And as you can see here, it was published in the supplemental material of the trial. It was dose dependent, meaning those that had a higher number of baseline robotic cases had a much lower rate of conversion to open. So most likely the trial was negative because not all surgeons at that point were expert surgeons. So for that reason, a randomized trial of laparoscopic versus robotic TME was performed in China. It's called the REAL trial. It was a multi-center randomized trial. It was designed as a superiority trial. It was conducted at 11 hospitals in 8 provinces of China. The trial was including 1,240 patients with middle or low rectal cancer that was locally advanced, and the patients were stratified according to center, sex, BMI, tumor location, and the use of preoperative chemoradiation therapy. Patients were randomized 1-to-1 to robotic versus laparoscopic TME, and the primary outcome was 3-year local recurrence rate using a modified intention to treat analysis. The first short-term outcomes were published in Lancet Gastroenterology in 2022, and they were very promising. As you can see here, patients who underwent robotic surgery had a far higher rate of complete removal of the mesorectum. The circumferential resection margin was lower in patients who underwent robotic surgery. As you can see here, completeness of the mesorectum was higher in patients who underwent robotic surgery. The long-term outcomes, so the primary endpoint has still not been published. We're awaiting the results, hopefully in the next few months to come out. And this may be the first trial to show superiority of robotic surgery versus laparoscopic surgery. No one knows what the future will bring. I think overall the future will bring personalization. We will know which patients will respond to chemoradiation, chemotherapy, or immunotherapy. It will bring precision. We will find out exactly what sequence and what type of therapy every tumor needs and which ones are immune hot and can benefit from immunotherapy. I think the future will bring more immunotherapy used as part of total neoadjuvant therapy, and very likely, as we saw from the OPRA trial, less surgery. But the future is still promising, and I don't think we can predict it. And that was my talk, and thank you very much for your time, and I'm happy to take any questions.
Thank you so much, Dr. Papu. That was an amazing overview of all the major clinical trials that we've been looking at. I really appreciate that review that you did. I do have a question for you. In regards to when these new studies come out and as these trials conclude, as we get more information, what are your recommendations on how to implement these changes for patient care at different institutions, different practice settings? Our audience consists of folks who are in private practice, who are in smaller institutions. What are your recommendations for working with teams to implement them?
That is a great question, Joyce. I don't think anyone has an answer. I would say whatever every institution does is probably best. You know, that what we have learned is it's not about the single individual, it's about the whole team. And I think the first and most important thing is to be honest with the patients. I think it seems to me that patients do benefit from care at specialty centers that do a lot of this. I can tell you, just remembering one of the first patients, that I think if you employ these novel treatments, it's best to do that within centers that have ongoing trials. Um, and you know, the bottom line is that the field is rapidly changing. I remember one of the very first patients who were in this New England Journal of New England Journal of Medicine paper with locally advanced rectal cancer. He was from South Carolina, and he had a low rectal cancer. He was 36. He had Lynch syndrome, and he came with his wife and their newborn, and he was devastated. He was a young lawyer, and they had told him locally that he would need chemoradiation and an APR. So, you know, something that would affect his fertility and a permanent stoma. And he came just for a second opinion, just in case we can avoid an APR. And he showed me on his iPhone, I can still remember it up until today, that, oh, you know, by the way, they told me that I may have Lynch syndrome. And he showed me the results that he was mismatch repair deficient, and said, you won the lottery. You know, we have a trial actually for you where you may not even need radiation therapy or an APR. You know, fast forward now, we're 5 years out. He is disease free. He's on, you know, he has passed the 5 year landmark really. And he has not had a recurrence. He had not required chemoradiation. He had not required an APR. So, you know, this is great for our patients. If we can employ a novel therapy that can make a landmark difference in their lives, I think that's very remarkable. Those, you know, small things that make a tremendous difference in the quality of life of the patients, they're really hard to capture in a trial. So I do think that you know, if you really care about your patients, if you have to be honest with them, and you have to tell them maybe there is a center that is doing a specific trial that may be applicable to you. And it is not a bad thing to refer them to someone who may be doing a trial that, you know, may be beneficial to the patients. In terms of the surgical technique, I would say that whatever the surgeon feels comfortable with is probably the best thing to do. Just because one trial shows that robotic surgery is better than open doesn't mean that this surgeon who is not necessarily familiar with robotic surgery should do that robotically. There are probably excellent open surgeons who should probably continue to do their surgery in an open fashion, because, you know, the time that it would take you to reach your learning curve and be able to provide this, you know, the excellent oncologic outcome with robotic surgery may not be worth it. So I would say to the surgeons that are out there, whatever you feel most familiar with and what your institution supports. Some people may not have the robotic platform, which may be another issue. You know, if even if robotics is superior, how do we make sure that actually all hospitals and all surgeons have access to being able to be taught? I think that's the next frontier. How do we teach surgeons how to do safe robotic surgery, and how do we, you know, guarantee access to more surgeons to those platforms?
I think that's a perfect way to end our lecture for today. Thank you so much again, Dr. Papu.
Absolutely, my pleasure. Thank you very much, everyone, and have a wonderful weekend, and enjoy your week.